Okay, to be mindful for the time, we're going to get started. So hi everyone, and welcome to today's webinar. I'm Hannah, I use she, her pronouns, and I'm a project management officer here at egale. For any participants who are not able to see me, I'm wearing a black hoodie, glasses, and have dark black hair. As moderator for today's sessions, I'll mostly be hiding in the background to make sure things run smoothly. Since we're doing this in a virtual format, I'll go over a few of the technical aspects to orient you before we get started. First, as you will have noticed, when you arrive, the session is being recorded for internal quality assurance purposes only. We like to remind everyone, for the safety and comfort of everyone attending, screen recording is not permitted. Next, for anyone who isn't yet familiar with Zoom interactive features, I'd like to take a few quick moments to run through the interactive features with you all. First, you should see a ribbon with the buttons such as chat at the bottom of your screen. If you do not see these buttons, just scroll your mouse or swipe along the bottom of your screen and the ribbon should pop up. Clicking the chat button will open the chat pod. Once open, you'll see a drop-down menu that allows you to choose who can see your chat contributions. We encourage you to share your comments with everyone, but you're also welcome to send messages privately to the session host if you wish your comments to remain anonymous. I will also be dropping the session handouts into the chat pod throughout the session, so you will want to keep that panel handy. Please feel free to drop in any questions that come up for you using the Q&A pod at any point during the session. We may have chances to address some questions in the moment, and we've also reserved some time at the end to address anything that has not been submitted or anything that has been submitted. For all other types of discussion, I'd ask you to please use the chat pod. Also, please note that participant lines are in listen-only mode today, so you will not be able to speak throughout the session. All questions and comments must be submitted in writing. Also, please note that the closed captioning has been enabled for this session. If you'd like to show or hide the subtitles on your screen, click the CC button, which you can find beside the chat button at the bottom of your screen. Finally, if you encounter any issues during today's webinar, do not hesitate to reach out to me privately by chat. Before I pass the mic over to our researchers, I'd like to offer a brief introduction to egale and our land acknowledgement. For those of you who do not know us yet, egale is Canada's leading organization for 2S LGBTQI people and issues. We improve and save lives through research, education, awareness, and by advocating for human rights and equality in Canada and around the world. Our work helps create societies and systems that reflect the universal truth that all persons are equal and none is other. Although we have participants joining us from various locations, we at egale are located in downtown Toronto, and as such, I would like to take the moment to acknowledge that we are hosting this webinar on the traditional land of the Huron-Wendat, Seneca, Mississaugas of the Credit, and the Haudenosaunee peoples. It is also important to acknowledge that I myself am a settler on these lands that Indigenous peoples have been living and working on since time immemorial, and continue to have community on today. The social and economic powers afforded to settlers today is deeply tied to this history. It is important that all settlers today recognize the contributions and historic importance of Indigenous peoples and to commit to making the promise and the challenge of truth and reconciliation real in our communities. I ask that we all remain cognizant of the colonial context in which we are embedded as we reflect and discuss the topics of this session. And now on to Brittany and Kim. Thank you.
Thanks, Hannah. Good afternoon, everyone, and thanks for attending this webinar on the Action Through Connection project and the final research report called Healthcare Access Experiences and Needs Among LBQ Women, Trans, and Non-Binary People in Canada. The report was released in the fall of 2023, and we're really excited to tell you more about it. But first, some introductions. My name is Brittany Jakubiec, and I am the Director of Research at egale Canada.
Hi everyone, my name is Kim Seida. I use she, elle pronouns, and I'm a Senior Research Officer at egale. Myself, Brittany, and our colleague Celeste Pang, who's a professor at Mount Royal University, conducted this qualitative study in 2022 and 2023, and this project was funded by the Public Health Agency of Canada.
All right, first, let's get into the project background and the methodology. So why did we undertake the Action Through Connection project? It was important to explore the healthcare experiences of LBQ women, trans, and non-binary people in Canada because these populations face distinct health inequities and challenges. In the Action Through Connection project, we wanted to do three things. First, amplify community perspectives and expand the evidence base on LBQ health in Canada. Second, address silences and gaps in the existing literature. And third, to identify areas for collective action. In this community engaged research project, we had two overarching research questions. One, what priorities for health and healthcare access do LBQ women, trans, and non-binary people in Canada have? And two, what actions can be taken across sectors to address these priorities? For this project, we established 3 advisory committees, and they were made up of academics, community members, as well as practitioners and frontline service providers. The 3 committees provided key input into the project at various stages, including the Research Ethics Board application, the research tools, as well as the preliminary findings. In part 1 of the project, and after receiving ethics approval, we conducted virtual focus groups and individual interviews to better understand the health and healthcare access experiences of LBQ women, trans, and non-binary people in Canada. In part 2 of the project, not covered in this presentation, we created and piloted a national quantitative survey and hope to launch it in the future. We also worked with social artist Melanie Schambach on 3 posters that capture some of the participants' healthcare experiences and priorities. The report and posters are available in both French and English and can be found on the project landing page linked in the slide, egale.ca/LBQ. In terms of our participants, we had a total of 35 participants take part in 7 virtual focus groups and 7 virtual individual interviews, which were held in both English and French over Zoom. 1 focus group and 1 interview were conducted in French. Participants in the study were from 9 provinces, were between the ages of 18 and 69, were primarily from urban areas, and more than half of participants were Indigenous, Black, and people of color. There are more details on participant demographics in the final report. Now, let's move into exploring the research findings, and I'll pass things over to Kim.
Thanks, Brittany. All right, so the next section will focus on some of our main research findings. So we used reflexive thematic analysis to analyze all of our qualitative data, and we created 6 main thematic areas to capture participants' healthcare experiences. In this webinar, we'll be providing high-level takeaways from the 3 bolded thematic areas. And first, we'll look at the labor involved in accessing care. Then we'll turn our attention to participants' experiences accessing primary care. And finally, we'll discuss participants' experiences accessing sexual and reproductive health care. We welcome you to review the remaining thematic areas in the final report, which include experiences with gender-affirming care, mental health care, complementary and alternative medicine, as well as mutual aid. So let's begin with labor in accessing care. Many participants spoke about the labor that they had to conduct to access healthcare. By labor, we mean the various strategies people would use to advocate for themselves or others in efforts to better access care or improve the quality of care they received. Understandably, this effort took a mental, emotional, and physical toll, and participants described this experience as quite exhausting. Using these strategies was a direct consequence and response to the dismissal participants had experienced in healthcare settings, such as invalidation of their knowledge of their own experiences and identities. Multiple participants shared that they were not taken seriously or had to fight to be taken seriously. The dismissal and invalidation our participants described has been coined medical gaslighting. Medical gaslighting can be defined as when doctors or healthcare providers invalidate or dismiss health concerns, and sometimes this takes the form of telling people their health-related worries are quote-unquote all in their head. For example, the history of diagnosing women with hysteria is an example of medical gaslighting. And the dismissal of healthcare concerns is also connected to how medical providers and the discipline of medicine often pathologizes marginalized communities as a means of controlling them. Further, the experiences of dismissal that participants faced were intertwined with other forms of oppression, such as ageism, racism, sexism, and cissexism. All of these self-advocacy strategies and the labor that participants had to put into seeking out and accessing healthcare took an emotional toll. Participants described feeling exhausted, frustrated, anxious, fearful, and uncomfortable seeking care. One participant, Siobhan, shared, "Over the past 5 years, I've been dealing with a lot of chronic pain. So now I'm looking at getting diagnosed with endometriosis. I've been fighting for that for years, and the biggest barrier is just getting someone to take me seriously. It's so hard advocating for yourself and trying to express to people how much pain you're in because it's not a physical thing. I have to communicate constantly, and I have to get really good at my communication skills." Siobhan's example describes a form of self-advocacy in a healthcare setting. Other forms of advocacy, either for oneself or for others, which participants described, included being persistent, changing their language, for example, how they described their symptoms or the jargon or vocabulary that they used, or even their tone of voice. They also asked a lot of questions and made concerted efforts to communicate their needs in effort to receive both appropriate and adequate health care. Participants described the mental labor involved and how they would develop strategies before even setting foot in a healthcare setting. And some participants drew on their knowledge of their healthcare system to assist in their navigation of it. For example, Riley had worked in healthcare and Rita came from a family of healthcare professionals. Both participants, whose quotes are on the slide here, used this knowledge to improve their healthcare experiences. Riley said, "I'm kind of coming into most healthcare interactions as a bit of a double agent because my training is in healthcare. I tend to spend a lot of time before appointments or referrals, almost problematically ruminating over what's going to come up and what we're going to ask, rehearsing answers, and trying to figure out how I'm going to get my needs across." Rita similarly shared, "I'm really good at being an advocate everywhere I go. I always feel like I have to have this toolkit of knowing exactly what my rights are. Part of the reason is because I'm not white, and so they don't take me seriously. And then you add menopausal, and instantly you go off in another category." Rita's experience that was shared with us clearly illustrates how various forms of discrimination and marginalization, namely racism and ageism, intersect to create barriers to care and put healthcare seekers in a position of needing to advocate for their own healthcare needs. Like Riley and Rita, many participants had to fight to be taken seriously in healthcare settings and had to put in that emotional energy and mental energy, as well as various strategies to get the care they desired and needed. One of the healthcare domains in which the labor involved to maximize the quality of care participants received was that of primary care, which is the second theme that we'll explore today. In terms of accessing primary care, participants talked about their experiences trying to find and interacting with primary care physicians and family doctors. They also shared numerous cost-related barriers to primary care, and they described their use of the emergency room in lieu of primary care, and this was often a direct result of not having a family doctor at all. Participants shared that impeded access to primary care affected their overall health and well-being, and they described how intersecting social locations, so for example, that could be socioeconomic status or ethnicity, fundamentally shaped their primary care experiences. Participants wanted to see changes to primary care at a systemic level and wanted greater access to competent, affirming, and affordable healthcare. Participants, especially trans and non-binary folks, worried about whether their care provider would be consistently and respectfully gender affirming, for example, using their names and pronouns, especially if that was different from their legal documentation. Because of these concerns, some participants put off or delayed seeking healthcare or adjusted their strategies in seeking care. For example, Mary, whose quote is on the slide, shared, "Just being trans always makes me really anxious anytime I have a first interaction with someone, because I don't know how they'll treat me as a trans person. A lot of the time, it helps if I can Google them and see that I can expect to have positive interactions because they look like they're queer positive for whatever reason." Mary's experience highlights the labor involved not only during, but also before healthcare encounters. In addition to difficulty finding or interacting with primary care providers, participants also shared cost-related barriers to primary care. Although Canada purports to have a universal healthcare system, there's an issue of privileged access. Folks with privileged access may be those who can access care through their student status, private healthcare insurance, or their ability to pay for private clinical care out of pocket. Participants who could access care through private insurance felt quite privileged and lucky to have this access. Conversely, participants who had previously had coverage under their student insurance plans experienced difficulties navigating coverage options now that they were no longer students. Participants also spoke about aging out of provincial drug coverage programs, such as Ontario's OHIP program, and were worried about finding new solutions to paying for medications after they turned 25. Participants' frustrations about the various costs of primary care, as well as concerns about their ability to function in the day-to-day as a result, were summed up by Preeti's statement. "Everyone talks about how Canada has free healthcare, but actual Canadians know that it's not inclusive healthcare. There's this exclusion of going to the eye doctor or getting an eye exam. Dental isn't covered. Mental health care isn't covered. I don't understand. Are eyes not part of our bodies? I don't really get it." In sum, participants' primary care experiences were characterized by barriers related to the availability of primary care physicians and the cost of care, uncertainty about gaining access to needed care, and finally, exhaustion about this uncertainty and the self-advocacy needed to optimize primary healthcare experiences. I'll now pass it over to Brittany to discuss our last theme.
Thanks, Kim. So for today's webinar, the last theme we'll discuss is the theme of sexual and reproductive health care. Participants in this study sought out sexual and reproductive health care for several reasons, and some participants experienced barriers or challenges in receiving the care they desired, such as feeling invisible or invalidated, confronting out-of-date or harmful assumptions about their identities, relationships, and sexual behaviors, negotiating identity disclosure, bi-negativity, bi-erasure, and biophobia, as well as other challenges outlined in the report. For some participants with minoritized sexual identities, they felt invisible or invalidated within sexual and reproductive healthcare settings due to heteronormativity, as well as assumptions about their identities, relationships, and sexual behaviors. For example, Serena, whose quote is on the screen, shared her experience of heteronormativity within a healthcare setting. She shared, "The doctors usually say, 'Are you sexually active?' And I'll say yes. And they'll say, 'Okay, are you using condoms?' I'll say no. And they're like, 'Are you trying for a baby?' No. They're like, 'Okay, so you're having unprotected sex?' And so I'm like, 'Oh, sorry, I'm having sex with a cis woman right now.' It's all just very heteronormative." Another barrier faced by some of the participants was the negotiation of sexual and/or gender identity disclosure. Participants were unsure whether to disclose this information and if it would be received with care. LBQ women, trans, and non-binary people navigate identity disclosure in sexual and reproductive healthcare settings and can worry about whether disclosing their identity could lead to dismissal of their concerns or even discrimination or stigmatization. Visual signs of inclusivity in these spaces can signal that their experience might be positive or affirming, but it's not guaranteed. For example, Jace, whose quote is on the screen, shared that her experience at a women's clinic, and she experienced stigma through persistent rejection of her queerness, when her healthcare provider referred to her wife as a support friend and questioned her wife's participation in her healthcare. Jay shared, "The journey started at the women's clinic, which was a terrible experience, and I'll tell anyone the reason why it was terrible. Because there are, of course, rainbow stickers in the lobby and pride flags, and then the nurse practitioner and the doctor referred to my wife as my support friend. And they asked me why I needed my emotional support friend, even after me repeatedly explaining to them that she was, in fact, my wife, and she was present because she has half of the information associated with the hell that is happening to me." Beyond the erasure and invalidating experiences described above, bisexual and plurisexual women can also experience bi-negativity, bi-erasure, and biphobia within sexual healthcare settings, wherein they can encounter things like disease narratives, hypersexuality narratives, and heterosexism. For example, Mira shared her experience of these harmful biases and her sense of feeling judged. She shared, "The doctor asked how many partners I had and if I had had multiple long-term partners, which I did, and then started to talk to me about having less sex and being very careful about protection with my partners. I said, my partners are also men and women, and that changed the tone of the conversation. When I disclosed to the doctor that I was bi, they said, well, that means you're having even more sex then. That's not what that means at all. I felt so targeted and felt so judged for a question that might have had something to do with the outcome of my healthcare." This participant's reflections of her experiences directly illustrate the sexual stigma associated with bisexuality and the assumption of hypersexuality or having more sex. This type of stigma can impact healthcare seekers on an individual level, but also at a systematic or institutional level, and can create barriers to accessing holistic and appropriate sexual health care for bisexual and plurisexual women, trans, and non-binary people. Altogether, these participant perspectives importantly shed light on what it meant to navigate the sexual healthcare system as an LBQ woman, trans, or non-binary person. From navigating disclosure with healthcare providers, as well as the aftermath of disclosure, to experiencing stigmatization for one's sexual behaviors, practices, and relationships, participants in this study experienced erasure, layered or intersectional stigma, and encountered harmful narratives. Ultimately, and across the board, participants experienced significant barriers in maintaining their positive sexual health. So moving on from our findings, we're going to now cover some of the recommendations from participants as well as those from the final research report. In this study, the 35 participants shared countless examples of when their access to or experiences of healthcare were problematic, harmful, or discriminatory. Altogether, participants shared nearly 100 recommendations for change or action. A few of these recommendations are displayed on the slide and can range from reduced wait times for all forms of healthcare, especially gender-affirming care, to the need for healthcare free from weight bias, to the need for updated policies to ensure healthcare is free from racism, transphobia, and other forms of discrimination and oppression. The full list of recommendations can be found in our final report, but to provide a high-level overview, the wide range of recommendations participants shared with us were grouped into three main types: those relating to education and training, healthcare practitioners, and health systems change. Education and training recommendations spoke to the type of content and topics that should be included in mandatory and incentivized training for healthcare professionals across various healthcare sectors. For example, an added focus on the health of LBQ women, trans, and non-binary people was of utmost importance to participants. The recommendations for healthcare practitioners speak to the need to recognize patients as partners in their care, the need for continual and ongoing learning and professional development, checking one's biases and assumptions, and embracing anti-racist and anti-oppressive practices. Finally, the recommendations for health systems change speak to the systemic challenges existing in our current health systems, such as the struggle to find primary care physicians, the long wait times, the cost of healthcare, as well as the need for more critical health research. And I'll pass things over to Kim for our next section.
Thanks, Brittany. So in addition to the final research report with our key findings and recommendations that we just reviewed, an important component of this project was mobilizing the knowledge that we gained in various ways. And so one of the ways that we engaged in knowledge mobilization was by translating the qualitative research findings visually through art. We partnered with social artist Melanie Schambach, and I believe Brittany will be putting the link to her personal and professional website now. And when we created a few posters, which I'll share in the coming slides. These 3 posters, which are in both French and English, capture and represent participants' healthcare experiences and priorities. So given that a salient theme of the data was around safer physical healthcare spaces, we thought it would be good to visually signify what a safer space looks like. This poster is called 12 Differences because the viewer can identify 12 key differences between frame 1 and frame 2, which are right above, or right, what frame 1 is right above frame 2. These differences speak to what participants shared about whether a healthcare space was welcoming or unwelcoming, safe or unsafe. For example, a few differences you can look for on the slide are the changes in the healthcare provider's badge, the form on the clipboard, the bathroom signage, the wall art, the seating area, how the healthcare provider is speaking to the care seeker, as well as many other differences. Also, this poster uses some of the wording participants used when describing their interactions with healthcare providers. For example, the top left frame illustrates a paternalistic healthcare interaction in which the healthcare provider is assuming that the healthcare seeker doesn't understand their own lived experience and ensuing healthcare needs, using the phrase, "No, dear, you don't understand." By contrast, the bottom frame shows what a more affirming healthcare encounter could look like, with the healthcare provider clearly telling the care seeker that they are there to help and advocate for them. As a result of not having to do that labor we were discussing earlier about advocating for themselves, the care seeker now feels that they're being taken seriously. And you can see that by the quote, "I feel like I'm being taken seriously," in the bottom left there. Earlier in the presentation, we talked about the emotional toll and the labor involved in seeking and accessing healthcare, and this poster called Armor illustrates these findings. The tagline of the poster reads, "We see your armor, you shouldn't have to wear it." The participant quote on this poster reads, "It's so hard advocating for yourself. And that over-preparing thing, if I say it this way, are they going to believe me? If I say it this way, are they going to totally dismiss me?" All of the visual cues in this poster speak to that additional labor, as well as the emotional toll and preparation people engage in going into a healthcare setting. For example, we talked about the anxiety and the exhaustion that people feel, and this is represented in the red colors of the poster. You can also note that the figure in the poster has a low battery on their armor and is carrying a cracked shield. These visual cues represent the burnout and exhaustion that participants felt, as well as their need to be on guard and protective of themselves. Finally, the third poster is called Community. In this poster, the participants quote, "If you're not serving us, you're not serving the community," has been made into a banner. This poster illustrates the diversity of folks in our communities who are lesbian, queer, bisexual, women, trans, and non-binary. And Melanie used a variety of colors to celebrate queerness and transness, to highlight the diversity of these communities and people, as well as to capture queer joy and resistance. As I noted earlier, these posters are available in both English and French and in various sizes, and they can be downloaded from our website at egale.ca/lbq. And we hope folks will print them out and put them up in your city, in your healthcare centers or community centers, in efforts to bring awareness to the research, but also the healthcare challenges and priorities of LBQ women, trans, and non-binary people all across the country. So, as our presentation so far has shown, this project used both qualitative and arts-based methodologies and efforts to amplify community perspectives and to expand the knowledge base on LBQ health in Canada. Also, this project aimed to address silences and gaps in existing literature, and finally, to identify areas for collective action. The posters we just shared, for example, highlight the characteristics of safer healthcare settings, the intensive labor in which LBQ folks engage when trying to access healthcare, and finally, the necessity of addressing the diverse needs of LBQ women, trans and non-binary people without prejudice or discrimination. So in conclusion, this project focused on two main questions. Firstly, what are the priorities for health and healthcare access for LBQ women, trans and non-binary people in Canada? And secondly, what actions can be taken to address these priorities? The first phase of the project revealed challenges around the labor required to access care, the impacts of having no or limited access to primary care, the impacts of postponing seeking various forms of healthcare, cost-related barriers, as well as harmful interactions and discrimination and the impacts of such interactions. We hope that these perspectives and recommendations shared so generously will be taken up and implemented to ensure that healthcare is accessible, equitable, and comprehensive for all. Thank you so much for your time and attention today. That's the end of our presentation.
Thank you, Brittany and Kim, for sharing the insights of the research. If folks have any questions, please feel free to use the Q&A pod and we'll answer all the questions that we can. If there are no questions at this time, that's no worries. Feel free to email research@egale.ca if something were to come up at a later time.
Oh, there's a question coming in from Leah.
Amazing.
We'll wait for you, Leah.
Did you want to tackle that, Brittany, or do you want me to?
I'll start with my first thought and then I'll pass it to you to add on to it. I was thinking immediately about some of the folks who participated from rural areas rather than urban centers, where we know that access to care is more limited in rural areas. And I think that when it came to gender affirming care or transition related care, those gaps were especially wide, where folks couldn't just, if they didn't live in a large city, they didn't have immediate access to gender affirming care or transition related care. Folks from more rural areas or from the Atlantic region often had to travel a really long way to get that type of care, which made cost barriers immediately increase as well. A lot of those costs had to come from out of pocket. That's one thing I noticed, and I'll pass it to Kim to see if there's anything else.
Yeah, thanks. I think as it relates to age, we noted it really briefly in the presentation, but ageism was certainly another axis of discrimination that folks described when accessing various forms of healthcare. So, for example, in reproductive healthcare, ageism took the form of, certain discourses surrounding pregnancy risk, as well as knowledge about folks, like validating their own knowledge about their bodies. More broadly, ageism took the form of that broader medical gaslighting that I mentioned, of just dismissing folks' healthcare concerns, writing it off, for example, as being connected to menopause, or especially if it's an invisible or invisibilized issue. That was certainly where ageism came into play. And in the report, we kind of note the irony of, the older you get, the more years of lived experience you have of being in your body, but yet you then encounter that kind of dismissal of your own needs and disbelief of your own framing of your lived experience when you're in a healthcare setting. So ageism was something that definitely came up. And then in terms of other differences, certainly racism was something that was really salient in healthcare encounters. So we know that there's a long sordid history of medical racism in terms of believing people's experiences of pain or pain tolerance, and that came up, or in terms of sexual behavior, all those kind of things, those emerged in participants' recollections of their healthcare encounters. So yeah, I would say racism, and that would be another really key area that we saw differences along.
Mm-hmm.
Thank you both. We have another question from Manu. They're wondering what implications there might be from this incredible work to push against privatization of healthcare in Canada.
You want to start, Brittany?
Sure. I mean, I'll speak briefly that we know that, with what we're seeing with privatization in other countries and now kind of increasingly in Canada, that this movement will lead to added costs for folks in accessing any type of healthcare. And we know right now that at least among 2S LGBTQI people in Canada, that many folks are struggling with employment, income disparities. We know that within StatsCan, there are multiple disparities in income. So any way in which we're adding costs to folks' plate means they will have to make hard decisions on whether they can access that crucial service or not. Meaning if costs increase, their access will likely fully decline, or they won't be accessing healthcare services. And I think within Canada, while the universal healthcare system is not perfect, I believe the right move is to keep investing in our public healthcare system. In terms of our time, our money, all of those things, we should be investing in that public system. I'll hand it over to Kim for anything else you want to say.
Yeah, I mean, that was very fulsome. I don't have too much to add to that, but what I will say is that a few months back, I was at a public health conference, and a few workshops and sessions were dedicated to the problems of accreditation and credentials not being recognized here in Canada. So a huge issue in Canada is that's contributing to the doctor and nurse shortage is a lot of foreign educated nurses and physicians' credentials simply aren't being recognized. And a lot of that is actually a relatively simple fix. So just putting pressure on that issue is something that I think would go a long way to addressing the shortages, which are a key reason why, or that's very interlinked with privatization. We're seeing a lot of folks move into the private sector that had been in the public sector. In another project that we did, we also saw that increasing socioeconomic pressures amongst even providers, whether that be primary care providers or mental health care providers, is pushing them out of public service into the private sector in efforts to make their own ends meet, right? So yeah, that's just a little addition that I would make to what Brittany said.
Thank you. Our final question is, how do you see different sectors collaborating to improve healthcare access for LBQ individuals in Canada?
When we asked participants about this, it was really a mixed response, where there were some cautions around sectors kind of communicating together and sharing information. And there were some concerns about what that would mean for folks. So folks like private information and how they'll be treated in those spaces. We also, and Kim, you had looked into kind of complementary care and mutual aid and things like that. We did hear a lot from folks about wanting to see investments in kind of community centers and community clinics, having more robust services available to them more locally, where they could go to their local clinic or community center and be able to access a variety of services. So I think that's one way in which sectors can be collaborating further. And there were a few really lovely examples of how that is working already in a few of our larger cities in Canada. And I think that's a direction we could be looking into, and how to make sure folks have access to multiple services, maybe within one setting or one location. Do you want to add anything, Kim?
Yeah, no, that's something that I've been thinking about ever since we did this research, in terms of this key element of trust, and how when we talk about intersectoral action that requires data sharing, and that comes with concerns that historically marginalized communities and have had with being surveilled, that sort of thing. So in response, I think, like Brittany was saying, building on the great work that's already being done in community spaces that have built trust in communities is a really great place to start. And further to what Brittany was saying too, in terms of sort of having multiple services under the same roof, those kind of hubs would be another great avenue to invest in, because it simplifies things. There's that element of trust that I was noting earlier. So yeah, that's just something I would add to that.
Thank you. We have another question. In your research, do you feel that WPATH, as it currently stands, is sufficient when it comes to informing trans healthcare, or are there any gaps that were identified during this study in particular?
And thinking about participants and what they shared, I didn't see anything specific to WPATH come up in the study. So I'm not sure if I could add anything to whether it's sufficient or there's gaps. I don't remember folks bringing that up actively in the focus groups or the interviews.
No, I don't either.
Mm.
But I know in another research project that I did, service providers talked about some gaps in WPATH, especially as it relates to like colonial constructs and kind of some underlying issues of racism or just unaddressed facets on that front. So that's not this project, but it did come up tangentially in another project. Oh, Brittany just posted it in the chat. That was the Queering Mental Health Supports in Canada project. So yeah, the service providers that we interviewed for that project, they brought it up, not often, but a couple of folks did bring up their personal concerns with it.
Amazing. Thank you both for the informative session, and thank you to everyone who attended today.